Hello again. We're going to consider some review questions for problems that occur during the neonatal and infant period. So question 1, we have a 4-week-old baby boy who presents with his mother complaining of poor feeding. Mother states that she's had difficulty getting him to nurse as he's reluctant to feed, and when he does, it's usually for about 5 minutes, and she's breastfeeding. Pregnancy, labor, delivery, and neonatal course were uncomplicated. He was born term at 6 pounds 9 ounces and presently measures 6 pounds 11 ounces at 4 weeks old. On examination, you note mild jaundice, an umbilical hernia, and an anterior fontanelle measuring 3.8 centimeters. Which of the following is the best next step in the management of this patient? A. Referral to a lactation consultant. B. Surgical repair of the umbilical hernia. C. Switch to formula feeds. D. Thyroid function tests. Or E. Admission and nutritional monitoring. All right, the answer to this question is D, thyroid function tests. So this is a classic presentation of an infant with hypothyroidism. Congenital hypothyroidism involves reduced activity, hypotonia, a large anterior fontanelle. The range is anywhere between 0.6 to 3.6 centimeters, the average being about 2.1 centimeters. This child was 3.8 centimeters. Poor feeding, poor growth, jaundice, as a result, decreased stooling, constipation, and a hoarse cry. So these are some of the things that we kind of see in adults. So in adults, they're going to be kind of tired. They're not going to be very hungry, so they're going to have a decreased appetite. That's going to cause poor feeding. And then constipation is another feature of hypothyroidism in adults as well. So these are your symptoms for hypothyroidism in young children, in infants. In most cases, the baby will appear normally initially. So at birth, typically the baby with congenital hypothyroidism, because the baby's been getting thyroid hormone from the mother, typically the baby will appear normal initially. Later on, and by later on here, I mean if this goes on, if this baby were to go untreated and go into his toddler years with hypothyroidism untreated, they develop coarse facial features, macroglossia, umbilical hernia, which can happen a little bit earlier, like in this patient, pallor, myxedema, goiter, mottled, cool, or dry skin. In most cases, congenital hypothyroidism will be detected on a routine newborn screening examination. But in the event that you suspect congenital hypothyroidism, the best initial test is going to be your thyroid function tests, and that's to get a TSH and free T4 level. So this child probably got a routine newborn screening examination, but those typically take about a month or a month and a half to come back. So it's very possible that this child just hadn't gotten the results yet. The treatment for congenital hypothyroidism is levothyroxine. You'll monitor your T4 and TSH, and the reason we do that is because we give thyroid hormone and we do it just enough to get that TSH level to the upper limit of normal. So that's how we monitor it and titrate it. You'll also want to consult pediatric endocrinology and then get an echocardiogram as well. Question 2. A Gravida 2 Para 1 mother delivers a 5-pound 2-ounce baby girl at 32 weeks and 4 days of gestation. There were no pregnancy complications and labor and delivery was uncomplicated. APGAR scores were 5 and 6 at 1 and 5 minutes. On delivery room examination, you note intercostal and sternal retractions, mild cyanosis, and a respiratory rate of 65 respirations per minute. Infant appears normal otherwise. High flow oxygen via nasal CPAP has been started. Labs are pending. Presently, the infant is saturating at 92%. The chest x-ray reveals bilateral atelectasis and air bronchograms. Which of the following is the best next step in management? Observation on nasal CPAP, B, intubation and surfactant administration, C, IV betamethasone, D, broad-spectrum antibiotics, or E, axial CT scan. Okay, the answer to this question is B, intubation and surfactant administration. So this is a child with hyaline membrane disease, and you would expect to see hyaline membrane disease in a preterm neonate. Now, this isn't tremendously common because a lot of times we can expect hyaline membrane disease when you have a mother who's in preterm labor. It's preferred that you, when you have a mother that's in preterm labor, that you administer IV betamethasone, and it has its best effect, optimal effect, if it's given 24 hours or more before labor, before birth, before delivery. So if you're giving it 1 hour before the baby is born, it's probably not going to help very much. Hyaline membrane disease affects 5% of all babies born between 35 and 36 weeks of gestation, and 50% of babies born between 26 and 28 weeks. And this baby was at 32 weeks, 4 days of gestation, so you're talking about like a 1 in 5 chance, but it does happen. Surfactant deficiency results in collapsing of the airways and then atelectasis, which gives you that condensed appearance on chest x-ray, and it's just going to look like a whited out lung because you have diffuse atelectasis, because you have a complete deficiency of surfactant. It's everywhere in the lungs. There's deficiency in surfactant. So it's bilateral and diffuse. Symptoms, of course, are going to be respiratory distress. Because there's collapsing of the airways, there's a decreased air movement, reduced lung sounds, and then nasal flaring is a sign of respiratory distress. Diagnosis is via chest x-ray. That gives you your diffuse bilateral atelectasis. Because there's condensation of the lung tissues, the few airways that are open, you'll see air bronchograms and then hypoinflation. The treatment for hyaline membrane disease is supplemental oxygen via nasal CPAP, which we've already started on this baby. The next step is going to be then to intubate the baby for surfactant administration. So when you have a child, I kind of talked about this earlier, but when you have a mother who's in preterm labor, the risk of hyaline membrane disease can be reduced by administering betamethasone, which accelerates surfactant production in the baby. Artificial surfactant is administered prophylactically for all neonates born at 27 weeks of gestation or earlier. So this child, you would not administer prophylactic artificial surfactant, only in the setting of symptoms, which this baby has. So initially, you're starting nasal CPAP, and then you're going to intubate the baby and provide surfactant. So this is what hyaline membrane disease would look like. This is also called respiratory distress of the newborn, which is sort of a general term. I don't really like it, but hyaline membrane disease sort of gives you a better idea of what this is. When you're approaching a baby with respiratory distress, you may not know immediately what the baby has, and that's okay. So what your first goal is as a physician to do is keep the baby alive. And so you're going to approach newborn respiratory distress the same way as far as treatment, immediate treatment, and then you can do your diagnostics later. So supplemental oxygen should be given. Typically this is done by nasal CPAP. This is warmed and humidified air sufficient to maintain a pulse ox of 92 to 96%, and or a saturation, pressure of oxygen, partial pressure of oxygen at 60 to 70 millimeters of mercury. You also want to monitor for apnea, and then you are also going to make sure that the kidneys are working fine, monitor urine output, glucose, electrolyte levels. If congenital pneumonia can't be ruled out, then you will administer broad-spectrum antibiotics. And that would be a case, for instance, where you have a mother with group B strep, for instance. You'll intubate if there's any of the following. If there's apnea, if the partial pressure of oxygen goes below 60 millimeters of mercury on more than 60% oxygen, or if the partial pressure of CO2 goes above 60 millimeters of mercury. And also note that cyanosis that doesn't respond to supplemental oxygen is probably due to a congenital heart defect. Okay, question 3. So we have a gravida-4 para-3 mom who delivers a term baby girl weighing 8 pounds 3 ounces, 18 inches long. Apgars are 8 and 10 at 1 and 5 minutes. On nursery examination, you notice epicanthal folds, a single transverse palmar crease, and a mildly protruding tongue. At 12 hours of life, the baby develops bilious vomiting. Meconium has not yet been passed. On physical exam, the abdomen is mildly distended. Which of the following is the best next step in diagnosis? A, an abdominal x-ray, B, abdominal sonography, C, upper GI contrast series, D, pass an NG tube, or E, karyotype. All right, so the answer is A, abdominal x-ray. So here you have a child who has apparent Down syndrome based on the clinical presentation. And anytime you have a child with Down syndrome, when you have bilious vomiting or what appears to be a GI blockage, the first thing you're thinking of is duodenal atresia. So duodenal atresia is a relatively common problem. However, you're going to be consulting surgery right away because this is going to require surgical correction. So you'll start out. I should say that your diagnostic tests can be abdominal X-ray. Remember, the stereotypic sign that you see in abdominal X-ray with duodenal atresia is the double bubble sign. You'll start your management out with NG decompression. You get everything out that's already been given because all that stuff's going to be vomited up anyway eventually. You'll shift the child onto IV fluids and nutrition. And then the question then is, do you want to do surgery right now or not? Now, if that really is up to the surgeon. In a lot of cases, you will just go ahead and do surgery. However, if for some reason the surgeon does not want to do surgery right away, then a contrast enema should be performed to rule out malrotation. And this can also be, I believe you could also do an upper GI contrast series too. And so we're just looking to make sure that all the intestine are where they should be. And so the reason we do that is because with malrotation, you can get a double bubble sign. All right, so postoperatively, actually, no, it's if you have malrotation with volvulus, and so we want to just make sure there's no volvulus there. So postoperatively, observation, continue parenteral nutrition until stool is passed, and prophylactic IV antibiotics. Also note that annular pancreas can give you the exact picture of duodenal atresia because you have a blockage in the duodenum, and so you'll get your double bubble sign. You won't know until surgery, and in that surgery you see that there's a loop of pancreas that is compressing the duodenum. In that case, the management is exactly the same. You're going to do a duodenostomy, but important to remember, do not ever divide the annular pancreas. That will lead to a whole can of worm of problems. So don't do that. Dropped my phone here. All right, so I think that's all I wanted to talk about here. So just a brief note on malrotation with volvulus. The reason that we do those the contrast enema or the upper GI series is because we want to make sure that there is no volvulus. Sometimes that can look the same as duodenal atresia, and it can give you the exact same picture on abdominal x-ray, and if there is a volvulus, we need to treat that right away. That cannot be deferred. So if you're deferring surgery, you want to make sure that there's no volvulus. If you're going to do surgery right away, then you don't need to do any contrast series because the surgeon will know. when they perform the surgery, and that can be treated during the surgery. So here's your double bubble sign. Question 4. A primipara mother delivers a term baby boy. Pregnancy course was unremarkable. APGARs were 8 and 10 at 1 and 5 minutes. On examination at 12 hours of life, you note jaundice and scleral icterus. Examination is otherwise unremarkable. Total serum bilirubin is 9.5 milligrams per deciliter. Direct bilirubin is 0.9 milligrams per deciliter. Direct Coombs test is positive. Mother is type O negative. Baby is type A positive. Which of the following is the most likely diagnosis in this patient? Physiologic jaundice, B. Hereditary spherocytosis, C. Hereditary elliptocytosis, D. Neonatal hepatitis, or E. ABO incompatibility. Okay, so the answer to this question is E, ABO incompatibility. Now, I suppose this could have been actually, no, I'm sorry. I did make this right. Okay, so this is a primipara mother. This is a mother who's never been pregnant before. So she cannot give birth to a baby with Rh isoimmunization. The reason is because it takes that first baby to sensitize her, then she develops the antibodies, and then with a subsequent pregnancy, if it's a baby that's Rh positive, then you can have Rh isoimmunization. So I should have probably put in Rh isoimmunization as a choice here. But this cannot be Rh isoimmunization. Now, ABO incompatibility is a similar process, but this can develop in a first pregnancy. So virtually all, this is physiologic jaundice. All right, well, this isn't physiologic jaundice, but we'll talk about it here. Virtually all babies will have some degree of physiologic jaundice as the baby transitions from reliance on the placenta to clear the bilirubin onto the baby's own hepatic system. So physiologic jaundice is never visible on the first day of life. This baby had jaundice at 12 hours of life. So this is not physiologic jaundice. Right there, you know this is not physiologic jaundice. The total serum bilirubin can rise up to 5 milligrams per deciliter per day up until day 3 to 5. Conjugated bilirubin will never pass 2 milligrams per deciliter or 20% of the total serum bilirubin, whichever is lower. So in this case, the direct bilirubin is certainly less than 20% of the total serum bilirubin, and it's also less than 2, but remember that ABO isoimmunization, ABO incompatibility is an indirect jaundice. So this is not due to direct hyperbilirubinemia. This is an indirect hyperbilirubinemia. The total serum bilirubin should peak around day 3 to 5 in physiologic jaundice, and then the visible jaundice should resolve by 1 week of age in a full term and 2 weeks of age in a premature infant. So here's your differential for pathologic jaundice, which this is pathologic jaundice. We know that this is an indirect hyperbilirubinemia because the direct bilirubin was not more than 20% of the total serum bilirubin or more than 2 milligrams per deciliter. So we know that it's an indirect hyperbilirubinemia. Next step is the Coombs test. The Coombs test came back positive, so we're left with Rh isoimmunization or ABO isoimmunization. And the answer to this is, of course, ABO isoimmunization because this is the first child delivered, or the first pregnancy. She was gravida 1. Okay, here's ABO incompatibility. So this is an attack on fetal red blood cells by maternal anti-ABO antibodies. ABO incompatibility is typically rare and seldom as severe as Rh incompatibility, where with Rh incompatibility you can have a stillborn infant, hydrops fetalis, etc. Typical presentation is a newborn with jaundice on the first day of life. The diagnosis is that you have an indirect hyperbilirubinemia with a positive Coombs test, and then ABO incompatibility with mom. And this was a type A baby with a type O mom, so mom is going to make antibodies to the A blood cells from baby. Also rule out Rh incompatibility if necessary. That was not necessary in this case. Treatment is to monitor and provide UV phototherapy if necessary, and you can use your nomogram for that. I'm pretty sure on the test they're going to give you the nomogram if you need it. Question 5, we have another prima gravida that delivers a term baby girl at 6 pounds 7 ounces. APGARs were 8 and 10 at 1 and 5 minutes. On nursery exam, you note a machinery murmur and a baby appearing as the indicated picture. I'll show you that next. Which of the following is the most likely intervention that would have prevented this condition? A, maternal penicillin G, B, appropriate parenteral nutrition, prenatal nutrition, C, adequate maternal immunization, D, avoidance of cat feces, or E, cesarean section. So this is what the baby looked like. Okay, get that picture in your head or pause it right now. We'll go back to the answer choices. So maternal penicillin G, appropriate prenatal nutrition, adequate maternal immunization, avoidance of cat feces, or cesarean section. This is a child that looked like that picture and also had a machinery murmur. All right, the answer to this is C, adequate maternal immunization. This is a case of congenital rubella. You have the blueberry muffin baby. Now, the blueberry muffin baby can be other things than congenital rubella. You can see that elsewhere, but what you don't see elsewhere, typically don't see elsewhere, is the machinery murmur. That is typically seen with congenital rubella. You won't always see the machinery murmur with congenital rubella, and you can have a machinery murmur with, and this is just a patent ductus arteriosus, but you can have that in other syndromes, and you don't always have machinery murmur in congenital rubella. But if you have a machinery murmur plus a baby that's a blueberry muffin, you probably have congenital rubella. And this can be, if the mom didn't have her prenatal labs done to look for rubella antibodies, you can certainly get that. So congenital rubella is, of course, an infection with the rubella virus. From birth, congenital anomalies occur when the mother contracts the virus during pregnancy, particularly during the first trimester. And this is less common in the US due to mass immunization against MMR. Problem now is that people think that these vaccines can cause autism, or they can cause other, they're thinking they don't need to get their vaccines, there's some conspiracy from the government or whatever. People are miseducated and think, and it's unfortunate. And so it's your responsibility as a physician to really highly stress the importance of getting vaccinated, especially if you plan on getting pregnant. But really everybody should get vaccinated for this stuff, especially their MMR vaccine. The manifestations of congenital rubella in baby is intrauterine growth retardation. So we saw in this baby, 6 pounds 7 ounces. It's a little light for a baby girl, that term, on the lower end of normal. Hepatosplenomegaly can be noticed, jaundice, papular rash, which is the blueberry muffin rash, cataracts, retinopathy, congenital heart defects, patent ductus arteriosus, that gives you your machinery murmur, and sensory neural deafness. Be sure to ask mom about any possible rubella infection during her pregnancy, especially if she denies ever having been vaccinated. Symptoms in adults includes rash, arthritis, adenopathy, and fever, rather nonspecific. So what we typically do is during the pregnancy, family practitioner or OBGYN is going to get rubella titers on mom to make sure she has proper immunization status. Now, if she was exposed to rubella, then she may not need the immunization, but usually women you come across in the US will be positive for being immune to rubella, and so you won't need to worry about this. But if the woman was never vaccinated or never exposed to rubella, and then she gets exposed to rubella, particularly in the first trimester, this is something that will happen as a result of that. So the best initial diagnostic test when you have a baby who is suspected of having congenital rubella is to get rubella titers, as well as to know the mom's immune status against rubella. Echocardiogram should also be ordered. You're looking for congenital heart defects, especially PDA, and then you'll also get an ophthalmologic exam looking for retinopathy. Treatment is supportive. There's no treatment for congenital rubella, unfortunately. So you're going to be directing your treatment at the manifestations. Question 6. A 14-month-old baby boy presents with his mother complaining of redness in the left knee. Mom says she noticed it yesterday. On further questioning, you find that mom's brother and uncle have had bleeding problems. On physical exam, you note a warm red fluctuant mass on the left knee, but otherwise well-appearing boy with appropriate motor development. On review of medical history, you note that there was prolonged bleeding at his circumcision site. Which of the following is the most likely diagnosis? A. Dietary vitamin K deficiency. B. Bernard-Soulier syndrome. C. von Willebrand's disease. D. Hemophilia A. Or E. Wiskott-Aldrich syndrome. All right, answer to this one is hemophilia A. So particularly, probably the giveaway here is the fact that mom's brother and uncle had bleeding problems. Anytime little boy comes in with something and mom's male relatives had similar things, you should think that this is an X-linked recessive disease. And in fact, hemophilia A is X-linked recessive. So what we see here is a warm red fluctuant mass of the left knee. This is a hemarthrosis, and this is a way that hemophilia can present. Now, also hemophilia can present as prolonged bleeding at the circumcision site, but if the circumciser was not paying attention or just said as prolonged bleeding, might not get a diagnosis if they don't, do the appropriate labs to work that up. So it doesn't always get diagnosed early on. And so since this wasn't diagnosed, baby was fine for most of his life until he started walking and crawling. And walking starts to happen around 12 months of age, 15 months of age. And what do babies do when they walk? They typically fall. And where do they fall? They fall on their knees. And so you can get a hemarthrosis there. The other syndromes, Bernard-Soulier, von Willebrand's disease, these are not going to cause hemarthrosis. Neither typically will vitamin K deficiency. And then Wiskott-Aldrich syndrome will usually give you a presentation that includes. They usually have dermatologic manifestations. They also have immunodeficiency, so that's not in this baby. Okay, G2P1 mother delivers a term baby girl weighing 7 pounds 4 ounces. Pregnancy, labor, and delivery were uncomplicated. At 1 hour of life, you're called in for a cyanotic spell while the baby attempts to feed. When the baby cries, the cyanosis improves. A 6 French catheter is not able to pass through the nasal passages. Which of the following is the best next step in the management of this patient? A. Axial CT. B. Urgent surgery. C. Orotracheal intubation. D. Nasal CPAP. Or E. Tracheostomy. Okay, the answer to this one is C. Orotracheal intubation. So this is choanal atresia. And choanal atresia is a maldevelopment of the nasopharyngeal tract resulting in obstruction. Now, this is not life-threatening if it's unilateral. However, if it's bilateral, it is certainly life-threatening. Babies are obligate nose breathers, and therefore, when they feed, they're not going to be able to breathe. And that results in cyanotic spells until they start crying, and when they cry, they will then breathe through their mouth, and that results then in a remittance of the cyanosis. This is an emergency. This needs to be treated right away. The first thing that you're going to do is secure the baby's airway. And that cannot be done by nasal CPAP because the problem is in the nasal tracts. So you'll need to secure airway via orotracheal intubation. A tracheostomy is theoretically something you could do, but that's not something you're going to do emergently. Tracheostomy is something that you would do if you needed prolonged intubation, but you won't need that in this case. You'll do orotracheal intubation and then send this kid off for ENT surgery. So the symptoms: baby is normal at birth. Baby is usually crying when they're born, but then becomes bradycardic and cyanotic when crying stops or when the baby tries to feed. This can reasonably be suspected on the stereotypic clinic presentation. In this case, a 6 French catheter was passed through the nose and met obstruction. And so you weren't able to pass that catheter through the nose and down the pharynx. If suspected, you should intubate immediately. And then once you intubate, then you can go ahead and get your diagnostic testing to make sure that this is choanal atresia. And that's going to be useful for surgery as well. And that would be done via axial CT. So the treatment is intubation, get an axial CT to confirm, then get a pediatric ENT consult for surgical correction. You'll also want to get echocardiogram, and the reason is because this is part of the charge association. This is the A, atresia choanae, is the Latin for choanal atresia, and so you've got other possible manifestations that could be there, and so you want to get an echocardiogram to make sure that there's no congenital heart defect, because that can prevent a surgical that can cause a surgical complication. So you want to make sure there's no congenital heart defect before the kid gets wheeled off for surgery. So here's an example of choanal atresia bilaterally. So this should be open here. And you have blockage. Okay, so here we have a prima gravida mother who delivers a baby girl at 28 weeks, 4 days of gestation via emergent cesarean section, and she weighs 4 pounds, 8 ounces. Pregnancy is complicated by HELLP syndrome. The infant is admitted to the NICU. Cranial sonography is performed as it should be and reveals a grade 2 intraventricular hemorrhage. Which of the following structures is most likely to have sustained damage? A, the bridging veins, B, anterior cerebral artery, C, meningeal artery, D, posterior cerebral artery, or E, the germinal matrix. Okay, I'll give you some time to pause here. And the answer to this question is the germinal matrix. So the germinal okay, we'll talk about that after the next question. So, which of the following is least likely to have caused the intraventricular hemorrhage? A, rapid volume expansion, B, hypotension, C, prematurity, D, hypertension, E, seizure, F, metabolic alkalosis, or G, coagulopathy. So all of these things can cause intraventricular hemorrhage except for one of them. So on the USMLE, sometimes you'll get these questions where they ask you one thing and then they'll give you a follow-up question. Usually what winds up happening, though, is the follow-up question makes it very obvious what the diagnosis was, and so you won't be able to go back. That's one of the new versions of questions that they're asking now. In this case, the follow-up question didn't give away anything from the previous question. Okay, so the answer to this one is metabolic alkalosis. So intraventricular hemorrhage is associated with all of these things except for metabolic alkalosis. It is, however, associated with metabolic acidosis. So an intraventricular hemorrhage is typically seen, pretty much always seen in preterm infants, and the basic common problem is that there was a cerebral dysregulation of blood flow, and the most fragile part of the brain is the germinal matrix. The germinal matrix is a developing part of the brain, very, 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 very fragile, and the cells are full of mitochondria, and those mitochondria require a lot of oxygen. And so, if you don't get enough oxygen to the brain, this is going to be a part that dies off very quickly, and so you'll get programmed apoptosis, and the result of that is going to be necrosis of the germinal matrix. After you get necrosis, these arteries are going to bleed, and the bleeding will first happen around the ventricles. That would be a grade 1 intraventricular hemorrhage. Then the blood is going to pour out into the ventricles. So all of these things contribute to intraventricular hemorrhage. You may have more than one of these contributory causes. So pretty much always prematurity is going to be present, but other things such as birth hypoxia, neonatal seizures, hypertension, shock, hypoxia, metabolic acidosis, pallor, anemia, coagulopathy, rapid volume expansion, hydrocephalus, those can also be seen and can contribute to IVH. The correction is going to depend on the cause. So any of these causes, if they're present in the presence of intraventricular hemorrhage, you will treat those things, because if you don't, then you can get worsening. So there's really no one treatment for intraventricular hemorrhage. You're just treating the contributory cause. So there's various things that can be done here. Now, important to keep in mind that you're going to screen all premature babies for intraventricular hemorrhage. You don't wait until there's symptoms. This can lead to cerebral palsy and other problems. So you screen them with cranial sonography. If you have a diagnosis then from that, cranial sonography is very, very, very effective at diagnosing IVH. Then you're going to treat any of these contributory causes. So the etiology is most commonly HIE. This can also be caused from asynchrony on mechanical ventilation, metabolic acidosis, hypocarbia, hypoxia, vacuum delivery, coagulopathy. Also maternal hypertension is a risk factor as well. Symptoms are going to be early on consistent with anemia. You get pallor, poor perfusion. There can also be associated metabolic acidosis, glucose instability, hypotonia, apnea, respiratory distress, ultimately seizures, shock. There can also be secondary hydrocephalus as well. Diagnosis is cranial ultrasonography. That's the best initial test. Suspicious results should be followed up by MRI. However, you should be treating any of these underlying causes first, especially if you've already diagnosed an intraventricular hemorrhage. Preterm infants should always be screened regardless of whether they have any contributory causes that are present. Management is going to be to correct your underlying cause or causes, so correct any metabolic and fluid disturbances, refer the child to neonatology and pediatric neurology. Neurosurgery should be on board if there's a hydrocephalus. These babies should be in intensive care unit, manage any concurrent issues that are present, and then long-term follow-up. Okay, final question for this section. G2P1 mother delivers a term baby boy weighing 8 pounds 4 ounces. Pregnancy was normal. APGARs are 10 and 10 at 1 and 5 minutes. Nursery exam is unremarkable. At 24 hours, the infant has not passed meconium. On examination, there is mild abdominal distension. The rectal vault is empty. Abdominal X-ray shows multiple dilated loops of small bowel. Contrast enema shows a transition zone in the region of the rectosigmoid colon. Which of the following tests is the best next step to confirm your diagnosis? A. Anal rectal manometry. B. Upper GI contrast series. C. Biopsy of the sigmoid colon. D. Colonoscopy. Or E. Surgical biopsy of the transition zone. And the answer to this one is A. Anorectal manometry. So based on this clinical picture, you pretty much have your diagnosis without doing an anorectal manometry. This is pretty much for sure a diagnosis of Hirschsprung's disease. And when we have the clinical picture here, just based on these symptoms, that you've got an empty rectal vault, failure to pass meconium, mild abdominal distension. That's certainly consistent with Hirschsprung's disease. But then when you get this contrast enema and it shows you a transition zone, and what area is affected? It's the rectosigmoid. That's a very common area for Hirschsprung's to show up. And a transition zone is very consistent with Hirschsprung's because it shows an area that cannot relax. And it's the failure to relax that is hallmark of Hirschsprung's syndrome because you have a lack of ganglia in a portion of the large bowel. So to confirm your diagnosis, anorectal manometry is going to be preferred because this is a relatively non-invasive test and it's very specific for Hirschsprung's disease. Upper GI contrast series is going to tell you pretty much nothing that the contrast enema didn't show you. Biopsy of the sigmoid colon is a little too invasive, and plus the sigmoid colon is probably not going to be affected because the transition zone is the rectosigmoid. Colonoscopy will tell you absolutely nothing. Surgical biopsy of the transition zone theoretically would be the most accurate test, but that's not something you're going to do right now. That's something that can be done when you resect because ultimately you're going to resect the aganglionic portion, and that can be done to absolutely confirm that this is indeed Hirschsprung's disease. But the next test to confirm your diagnosis would be anorectal manometry. So Hirschsprung's disease is an absence of ganglion cells in the mucosal and muscular layers of a segment of the colon, and that's going to be the segment that can't relax. Proximal to that, you'll have a megacolon. The incidence is 1 in 5,000, so very common. 4 to 1 predominance in boys. It's associated with genetic anomalies, especially Down syndrome, but you can certainly have Hirschsprung's disease in a child with no other problems. Tends to affect the rectosigmoidal area, 80% of cases. In 15 to 20% of cases, it can extend proximal to the sigmoid, and then 5% or less of cases, it can involve the entire colon. The symptoms include failure to pass meconium, and then symptoms consistent with obstruction, such as vomiting, abdominal distension, reluctance to feed. You can get enterocolitis, rarely, that's usually if you have a megacolon. Then the empty rectal vault, because you've got failure to relax proximal, and so you're not going to get any stool. However, if you are able to get your finger up, if the aganglionic portion is distal enough to where you can get your finger and cross that aganglionic portion, suddenly you have opened the aganglionic portion and you have tons of back pressure proximal to that. And now that you've opened the aganglionic portion, manipulated it to cause it to quote-unquote relax, you are going to get an explosion of flatus and stool that could make a mess. But that's very, very specific for Hirschsprung's disease. Bouts of alternating constipation and diarrhea may be seen. Typically in older children, if they have Hirschsprung's, it's usually constipation. Yes, this can be diagnosed later on in life. Diagnosis, best initial test is abdominal x-ray followed by contrast enema and then anorectal manometry in that order. Most accurate test is a rectal biopsy. Also note that neonates may not show a transition zone until later in life, but they certainly can during the neonatal period. But do know that they may not show a transition zone. So if the suspicion for Hirschsprung's is high, then even though they don't show that transition zone on contrast enema, you should still go ahead and get a rectal manometry. The management, of course, is going to be surgery. The surgical consult will be warranted. They'll do a resection of the aganglionic portion, and then they'll do a diverting colostomy, followed then by a secondary takedown. Complications include fecal retention, incontinence, anastomotic breakdown, stricture, and general surgical complications.